Bismillahirrahmanirrahim. So the next topic in renal pathology is acute tubular injury, also formerly known as acute tubular necrosis. So acute tubular injury is one of the most common cause of acute renal failure, which is characterized by the rapid fall in renal functions. So what does rapid fall in renal function mean? It means there is decreased glomerular filtration rate, resulting in decreased urinary output or oliguria. Moreover, there is decreased excretion of creatinine and urea, resulting in increased blood urea nitrogen. So along with the rapid decline in the renal functions, there is also evidence of injury on the morphology. Acute tubular injury is actually a reversible process, and it is caused either by the ischemia or toxins. So ischemia occurs as a result of decreased blood supply to the renal parenchyma, and the causes of ischemia include hypovolemia, which means there is decreased blood volume, and as a result there is decreased perfusion of renal parenchyma. Moreover, there is disseminated intravascular coagulation, which is an acute complication of acute pancreatitis. Then there is thrombocytopenic purpura and hemolytic uremic syndrome. So all these three result in thrombosis and decreased renal perfusion. So there are some vascular diseases such as malignant hypertension and microscopic polyangiitis that also account to ischemia. So decrease in the blood supply results in the ischemia, and there is decreased oxygen supply to the renal parenchyma. So as a result, what happens is that there is loss of cell polarity. What is cell polarity? Cell polarity means differences in shape, structure, and functioning of different cells. It is the cell polarity which basically determines what the cell is specialized to do. For example, a neuron is specialized to conduct impulses. A red blood cell is specialized to carry oxygen, and neutrophils are specialized to fight the infections. Likewise, the tubular epithelial cells lose their polarity, and as a result, there is redistribution of sodium-potassium ATPase pump. So this is the renal epithelium. This side is tubular lumen, and this side is interstitium or blood. So this surface is basolateral surface, and this surface is luminal surface. So the basolateral surface have sodium-potassium at ATPase pump, which release sodium into the blood and take in potassium. So what happens as a result of loss of cell polarity is that this sodium potassium ATPase pump is redistributed to the luminal side of epithelium. So what it does on the luminal side is that it increases sodium excretion and reabsorbs potassium. So as a result, there is a higher concentration of sodium in distal convoluted tubule. So presence of increased sodium in distal convoluted tubule activates the renin-angiotensin system, which causes reflex vasoconstriction of blood vessels. This feedback mechanism is known as tubuloglomerular feedback. Moreover, there is also a decreased secretion of prostaglandins or prostacyclins, which are specialized prostaglandins, cause the dilation of blood vessels. Decrease in prostaglandin favors the vasoconstriction. Moreover, endothelial cells secrete endothelin in response to injury. Endothelin also constricts the blood vessels. So all these phenomena actually result in increased ischemia and decreased oxygen supply to the renal parenchyma, causing injury to the tubules. So the injured epithelium release cytokines, which recruit the inflammatory cells such as neutrophils to the site and contribute to acute tubular injury. So the toxins that affect the kidneys directly are known as the nephrotoxins, and these include myoglobin, which is derived from the muscle damage. A severe disease known as rhabdomyolysis occurs in the athletes after a severe workout or severe session of training in which the muscles are broken down and the degenerated components of myoglobin are excreted in the kidneys, resulting in acute renal failure. So rhabdomyolysis is a dangerous disease and constitutes a medical emergency. Moreover, there is hemoglobin that can also damage the kidneys, which is released in the urine in hemolytic uremic syndrome and paroxysmal nocturnal hematuria. Bilirubin is also excreted in the renal tubules when there is hyperbilirubinemia. Then there are certain drugs such as gentamicin and certain NSAIDs, which are nephrotoxic and damage the renal tubules. Radio contrast dyes, which are used in the contrast enhanced CT scans, are also nephrotoxic. Heavy metals such as lead, cadmium, and mercury are known to be nephrotoxic, and there are certain organic solvents such as carbon tetrachloride and ethylene glycol. So these toxins are actually the nephrotoxins, which means they damage the kidneys and they result in damage of the epithelium of renal tubules, resulting in acute tubular injury. So whatever the cause of the acute tubular injury, whether it is ischemia or it is due to the nephrotoxins, the injured epithelium slough off into the lumen and cause luminal obstruction. So as a result of luminal obstruction, there is increase in the luminal pressure, causing a decrease in glomerular filtration rate and development of edema. So coming on towards the morphology, first we will discuss the morphology of ischemic type of acute tubular injury. So tubular necrosis in proximal convoluted tubules, as you can see, this is a glomerulus and these are the proximal convoluted tubules. So there is a necrosis in proximal convoluted tubules, proximal straight tubule and Henry's loop with large skip lesions. So these are the necrotic areas and these white color are the skip lesions, which means they are unaffected. There are some necrotic areas in the ascending loop of Henle which are obscured by the presence of hyaline casts. So the necrosis is typically identified by the damage in the epithelial cells, and often there is rupture of basement membrane of tubules, which is known as tubular rhexis. Hyaline casts in the distal convoluted tubule and collecting ducts are also present. This is a collecting duct filled with the hyaline cast. So these hyaline casts are actually composed of glycoprotein, which is secreted by the thick limb, and they are known as Tom Horsfall proteins. So these proteins completely obstruct the distal convoluted tubules and partially in the collecting ducts. Moreover, interstitial edema is also present due to obstruction of the renal tubules, and the leukocytes are also present, such as neutrophils. So in contrast to the ischemic type of acute tubular injury, the toxic type of acute tubular injury almost completely involves the proximal convoluted tubules. As you can see, this is the glomerulus, this here is a skipped area, and then the proximal convoluted tubule and proximal straight tubule is completely involved. It was partially involved with the skip lesions in the ischemic type of injury, whereas proximal convoluted tubule and proximal straight tubule is completely involved in toxic type of acute tubular injury. The situation in the distal convoluted tubule and collecting duct is similar to the ischemic type of injury, which means they are filled with the hyaline cast composed of Tom Horsfall proteins. Necrosis is non-specific. Non-specific necrosis means that each type of nephrotoxin is causing a different type of injury, which appears in a different way on the histology. Such as in mercury chloride, there is acidophilic inclusions in the injured cells, whereas in carbon tetrachloride, there is excessive lipid accumulation in the cells. Moreover, there is ballooning of cells and vacuolar degeneration in ethylene glycol. So all these changes to the cells result in necrosis. The classical cases of acute tubular injury are classified into three phases, which include initial phase, then there is maintenance phase, and finally there is recovery phase. So initial phase lasts almost 36 hours since the onset of injury, and it results in minor decrease in glomerular filtration rate, resulting in decreased urinary output. There is increased blood urea nitrogen ratio, which means there is increased urea in the blood and increased creatinine in the blood. The next phase is the maintenance phase, where oliguria becomes severe due to decrease in the GFR and progression of the disease. The urine becomes concentrated. Since there is less volume of the urine and increased excretion of urea and creatinine in the urine, hyperkalemia is a deadly complication which can result in flaccid paralysis of heart, resulting in cardiac failure. Metabolic acidosis is present. Then there is uremia, which means increased urea in the blood and increased blood urea nitrogen ratio. So the urea and creatinine level starts to rise in the blood. The normal creatinine level is 0.7 to 1.3 milligram per deciliter in men and 0.6 to 1.1 milligram per deciliter in females. Whereas the normal urea level is 5 to 20 milligram per deciliter in the blood. So the last phase is recovery phase. So once damaged epithelium is replaced by the regenerative new epithelium, the kidney functions start to return, which is characterized by increased glomerular filtration rate, resulting in increased urine output. And there is increased loss of sodium, potassium and water. The creatinine and urea levels also begin to return to normal levels in the blood. The disease might also progress into acute renal failure, which is characterized by the complete absence of urine, or also known as anuria. So that concludes our session of acute tubular injury. If you have any questions, do let us know in the comment section. Thank you.